I have a question. I'm probably the most ignorant out of the three of us in terms of like anabolic steroids and bodybuilding. And, you know, I come from a little bit more of a sports background where I was told to just avoid them completely, right? I was wondering just for myself and for the audience in terms of like what the options are out there for anabolic steroids and what each one has in terms of their characteristics versus the other. You mentioned like DECA and testosterone, and like what are the other ones that are kind of out there, and you know what are sort of the pros or cons of all these things?
Great question. So there's a bunch of great steroids out there, anabolic steroids. And before I go in any further, so people use that term loosely, right? Steroids. Well, testosterone, estrogen, DHEA, progesterone, pregnenolone, they're all steroids.
Isn't cholesterol a steroid even?
Well, cholesterol is the molecule from which we derive the word steroid, like cholesterol, like steroid, right? So all these hormones that we're talking about, are made from cholesterol. So that's different than an anabolic steroid to which you're referring, right? A molecule that usually is either a testosterone molecule or often enough a dihydrotestosterone molecule that's been jiggered in such a way by removing or adding a ligand along the molecule so that when it goes into the cell, it operates differently, we'll say, than a typical testosterone molecule. And what we mean operating differently is typically, more of the anabolic properties will be emphasized, those that build muscle, accrete mass, rather than the androgenic side effects, the secondary male sex characteristics we call it. Accentuate the hair on the ears we get after we're in our 30s and stuff like that. The weird stuff that none of us likes, balding and stuff like that. So there are a bunch of different anabolics that have been developed. Unfortunately, we're limited as to what we can use in the United States. There are roughly, 4 that are used. There are more than that are actually legal. For example, there's something called halotestin, which I have no idea why anyone would ever want to use it. A lot of bodybuilders do because it makes you, and I'll put it mildly, kind of edgy. And if you're
powerlifters like to use that one, I heard. I guess it makes them aggressive,
ramps them up, right?
Yeah.
So bodybuilders, powerlifters is a great example. They'll use smelling salts to perk themselves up, if you will, right before a lift. Same idea with halotestin. With bodybuilders, it's more for, hey, I'm sucking wind here because I'm not eating prior to the show, and they want anything to get them through a workout. It's unfortunately really rough on the liver. And again, it can make you, edgy is an understatement, it can make you homicidal. So again, halotestin, I would say, hey, eschew that and have an extra espresso before workout instead. But we have some good anabolics that are useful for wasting disorders. I mean, that's what their standard, their indication is, right? Cachexia and wasting disorders, burn victims. So oxandrolone, used to be known as Anavar, is one of the best ones out there because not only is it anabolic in nature, it's also catabolic in nature. So you can actually put on muscle and lose fat at the same time, sort of the holy grail of what most people magical in life would like. Yeah. Yeah, and it's it can be used in females too. It's one of those that's a dihydrotestosterone derivative, and it doesn't convert to estrogen. Therefore, it doesn't affect the receptors, for dihydrotestosterone. So it's what we would consider a clean anabolic steroid. It's also, again, very useful for females because it doesn't convert to estrogen. So if someone has had an estrogen-sensitive cancer, they can use it without fear of propagating cancer yet again, an estrogen-sensitive cancer. So in that way, it's a wonder drug. A lot of bodybuilders use it prior to a show because that's exactly what they're trying to do. They're trying to lose fat and hold that muscle. There's one related to that called stanozolol, which used to go by the brand name Winstrol. And that one is very similar to oxandrolone, except it also, one of the indications is for angioedema. So it gets rid of the extra water, the third space water, the kind of water you don't want, not the water that stays in the cell, but the water that's in between cells. And so bodybuilders like to use that a lot too, or track athletes like you've heard.
That's what Ben Johnson got banned from the Olympics or whatever. Got his gold medal taken away for that.
And it makes sense, right? You would use that one over Anavar. Why? Because any athlete like that wants to carry as little extra as possible, yet still maintain the muscle mass and lose the fat, right? So that makes sense for track athletes to use Winstrol. Plus, I think it tends to pep you up a little bit too. That's just been my experience.
And that's you can prescribe that in the U.S.?
Yes.
Okay.
You can prescribe an oral form. You cannot prescribe an injectable form. And I may not be the one to quote when it comes to the legal aspects of this, because it might have changed. But that's my understanding, is that you can't do the injectable for some. I guess that's only for animals or something. There's some rationale behind it. I don't know. Okay. And by the way, you can't get an injectable Anavar either, which baffles me sometimes, because I think it would be more useful in some ways, for especially if you ever had to use a higher dose, like for a burn victim. There's a lot of talk about how these are hard on the liver because they're oral steroids and they're alkylated a certain way. In my experience, I've never seen elevations in liver enzymes because of these when used the way they're supposed to be used. And this will be probably more helpful for the nerds out there. But AST and ALT are typically referred to as liver enzymes. And yet you can have elevated AST and ALT because of just muscle tissue breakdown. And so a lot of times people who are on anabolic steroids have more turnover of muscle, certainly, right? And so, oh, look, that anabolic you're on is causing liver issues. No, it's not. And an easy way for physicians who are listening, or anyone else, to verify that is to get a GGT, which won't be elevated for muscle tissue breakdown, okay? And it's specific to, the liver, but also pancreas, biliary tract, et cetera. So you use that to compare and go, oh, look, my GGT is well within normal limits, but my AST and ALT are mildly elevated. You can assume that things are safe. And there's other ways to prove that, by the way. You can do a liver ultrasound to make sure it's not too fatty, which, by the way, is one of the typical side effects. Probably the most dangerous thing about an anabolic steroid is fatty liver, okay? Which tends to resolve after you get off the anabolic steroid. And it all makes sense, because what do anabolic steroids do? They help pack glycogen into muscles, right? So that they become
also do it to the liver then, I guess.
Better later. But the next step up after, once the muscle's filled for the moment, the next step up is to store the energy in the form of glycogen in the liver. So you can build a fatty liver fairly early. And I'll keep rambling here. Let me just ramble a little bit more, because I think your audience will appreciate this too. And I learned this from Franco Columbu way back in the day, God rest his soul. Bodybuilders, like I said, and especially back in the day, used to just want to get big. So you do a lot of lifting, a lot of eating, and a lot of sitting around. Well, you could very easily develop a fatty liver. And so they all knew after an anabolic steroid cycle to use something called, back then it was just inositol and choline. They're nowadays still considered pretty much a B vitamin, although they're still arguing about how to classify them. Now we add another amino acid called L-methionine, and we call them MIC-caps. 30 days of these MIC-caps in a high dose, where you're using 3,000 milligrams of inositol and choline and 1,500 of L-methionine every day for 30 days, divided all at once, and you'll get a squeaky clean liver.
Oh, wow.
Yeah.
Wow, fascinating.
And I say this because, fatty liver, the latest estimates is that 100 million Americans, that's a lot of us, have fatty liver, and yet there's no pharmaceutical cure. I don't care what they market it as, and I'm not naming names, but I'm telling you right now, we don't have anything to compare to these three simple ingredients that you can get over the counter.
Yeah.
Yeah, and not harmful.
All right.
Oh. Now, there are others. So back to your question, there's nandrolone, which used to be branded as Decaduralin, which is an injectable steroid, great for just putting on mass. It's essentially anabolic without being catabolic as well, like stanozolol and oxandrolone. And I use for HIV patients, it's fantastic, because you can put on 20, 25 pounds of extra weight in someone that unfortunately they can go through a bout of illness, and that 25 pounds can be a lifesaver. It's a no-brainer, and very little risk with. What are the risks with nandrolone? I say very little. According to the medicine, that elevation in lipids, the bad lipids, the LDL is supposed to be a bad thing, but again, for reasons we talked about earlier, I would argue that's a bunch of bunk. And so it's a no-brainer for someone with HIV who's underweight or even midweight to put a few extra pounds on if it's not stressing the heart or something like that. So, and then the other one, which again I don't understand why you'd necessarily want to ever prescribe it, is something called Anadrol.
Oxymethylone, is that the name?
I've never written a prescription for it in my life.
I heard that was referred to. God, this is back in the 90s. I had this bodybuilder that worked for me, and they called it gorilla roids. That was the nickname they gave Anadrol.
Well, isn't that 5? Didn't you say 4? That's not 5 right there, right?
There's the
Anadrol.
That's 5 now, yeah.
Oh,
Because I said there's 4 that make sense. Halotestin
So
makes no sense to me.
Got it.
And Anadrol makes no sense.
And there are other ones that are legal. There's something called danazol, which is called an anabolic steroid, but I don't see anything anabolic about it. What I use it for, rarely, but I've still used it, is if someone's on TRT and their free testosterone is on the low side in terms of percentage, like it might be 1.5% instead of 2% for some odd reason, I'll throw in a little bit of danazol, which really wouldn't do anything except reduce SHBG, which is binding the total testosterone so that the free testosterone comes up. But Anadrol, you said it was, what did you call it?
Gorilla juice? Is what it is.
I call it dinosaur juice, man. I don't know why anyone would want to be on that, but it's for people that are really having a hard time putting on weight. The indication, I think, is for, I want to say pernicious anemia. And there's so many other ways to treat pernicious anemia than putting them on Anadrol, which, by the way, has a major side effect for a lot of guys. It doesn't convert to estrogen, but it seems to activate the estrogen receptor somehow. And it makes guys just absolutely, crazy. The so-called roid rage that people talk about, by the way, is typically not because of anabolic steroids. Now, halotestin can have that side effect to it, if you will. I'd say that has a profile that makes guys aggressive, no doubt. But it's really estrogen out of control that turns Dr. Jekyll into Mr. Hyde. The guy at the gym who puts on 30 pounds, all of a sudden becomes really red-faced and puffy, and then at the water fountain used to be a nice guy, now he's a jerk. That's typically because he hasn't controlled his estrogen properly, not because of the anabolic steroids. And think about it. The guys that are the big yoke guys in the gym that are doing it right don't look like that and don't act like that. And as guys, we can talk about, well, why would he? He knows he's huge. He can kick everyone's butt in the gym. Why would he get aggro over anything? He's like happy-go-lucky. Right. Testosterone makes you feel that way. But anyway, that's the answer to your question. I hope. I mean, those.
Yeah, I have a follow-up to that. But
where does Boulderon fall on that? Like,
not that's considered contraband for humans anyway in this country.
Veterinary
equipoise, is what it's used for. Just like the injectable Winstrol is for.
Would you compare that to like is it more like Deca, or what would it be?
It is. It's got a structure similar to Decadurobalin or Nandrolone, but it can convert more easily. Everyone says Nandrolone doesn't convert at all, but I think roughly 20% of it can convert to an estrogen. Boldenone can convert more readily to estrogen, but it doesn't come with the side effect that everyone dreads with Nandrolone. We haven't talked about that. Yeah. Sorry, I skipped that side effect. Decadurobalin comes with, they call it Decadic.
Yeah. Okay.
Erectile dysfunction because for a lot of men, particularly the same ones that would react negatively to finasteride or dutasteride, Proscar, Propecia, and dutasteride goes Avodart. They don't produce enough dihydrotestosterone and have erectile dysfunction, which, by the way, is not as prevalent as you would believe based upon all the press. But it does happen. And so with Nandrolone, you get conversion to dihydronandrolone, which is very, very similar to it's very, very weak in effect. So it binds to the receptor that DHT would go to.
Oh,
so
it occupies the receptor, so DHT can't go do its job.
Yeah, and so some guys will react to Nandrolone with what they call Decadic, based upon the old brand name to it. Yeah.
Wow.
So I've also seen this rise in SARMs, and I wanted to see if you could kind of go over that in terms of what you've seen, the reasoning why people use them, and then also like maybe like some potential, negative effects of that.
SARMs are not my favorite. Now, I say that pleading ignorance because I can't keep up with all the SARMs. Guys are inventing these peptides more frequently than I can study them. And I knew this was coming because when I was still in, doing my prereqs prior to medical school, I can remember walking down the building in the physics department, mind you, in CSUN. And they had all these pictures of peptides on the wall, these different hormones and whatnot. Why is this in the physics department? Well, because peptides are made like Lincoln Logs, I think they are, or not Tinker Toys, whatever. But the one that you could put together different angles and all these things. And the sky's the limit as to what you can invent with peptides. And these SARMs that they're coming up with, all these peptides typically are going into the cell and doing all kinds of things. We haven't thoroughly tested them. So there's a reason right there where you go, hey, be careful, guys, with what you're buying out there. not only haven't been tested, but who knows how they're being made and what's coming with them, in terms of excipients and other, toxic constituents. And again, I don't mean to wave the prude button, but be careful.
But a guy like you has got to get almost annoyed seeing that, because I would think with all your extensive knowledge with hormones and knowing how much we've researched all these ones that you just talked about, there's so much more that we know about that compared to these SARMs, not to mention what we know as far as side effects and stuff, but also how much more effective like regular hormones are. So like, why would you want to take more risk for less results? Like this, it doesn't make sense to me.
Well, and that's really what I come to at the end of the discussion, practicality rules. We did a study, and a former partner of mine, with some athletes that volunteered and a supplier of Ostarine. And it wasn't an IRB, it was just a voluntary deal where guys said, hey, let's try this. And it was, now the dose was by the manufacturer, suggested at 25 milligrams, which I think is still what they use. And to your point, they had less result than even being on TRT, and certainly than an anabolic. And the side effects were worse if you want to consider the effect on the lipids worse. So the HDL plunged even more. The LDL went up even more. And you don't get the same benefit. Why? Now, I speculate it's because of good old American values of, hey, I don't want anybody telling me what to do. And people, and I get it, I'm a registered libertarian, don't want to have to ask a doctor for a prescription. And so they get these SARMs and the way they want to get them, and I, God bless them. But again, to your point, why not do what works? It's okay. I get it. It's what we have to deal with. I make a living at it. You have to go through the gatekeeper and qualify to get this particular substance and all that. But when it's an inferior product, I argue, okay, this is not the right battle to fight. Go somewhere else. Now, with the new SARMs though that I'm ignorant of, there's a lot of them. Even things like Rad 140 that have been around for a while, I got people saying, wow, this is great. And I just don't have enough experience with them to tell you, oh, yeah, it is better than, say, oxandrolone or something. I will say that a lot of those guys that test out these SARMs, though, have never done an anabolic, the ones that I talk to. And also, they're often stacking. So, was it the Rad 140 or was it the Rad 140 and the ibutamorin and the BPC 157, or better yet, the thymosin beta 4? What did what? And this is a big problem in the bodybuilding community because we're stacking now, unlike we used to in my era, where again, because we couldn't get it or we couldn't afford it, we did one thing at a time.
Yeah. Let's talk a little bit about how testosterone is administered, because the old way, which is, from what I've read, the best way, which is injecting. So you inject it intramuscularly, but then they've come out with creams that you rub on your skin. There's, I think they're called, I don't know if I'm pronouncing it right, trouches. Am I pronouncing that right? Or pouches? They're like,
I call them troches or troches.
Troches. There you go.
Troches, I think is excuse me, I think actually the way people say it, but I think if you look it up, I think it's from the French. I think you're supposed to say
Troche.
Something like that. Yeah.
Okay.
The common pronunciation is troche, so let's just stick with that.
So, and I guess it's like you put it in your gum and it absorbs, through the mucous membranes of the mouth or whatever. There's tablets. Like, what's the best form of administration from a, getting the testosterone levels where you want, getting people to feel the best type of, context?
And safest.
Yeah. So as always, it's individualized, but in general, I would argue that for a male, the best way is through an intramuscular injection of a esterified form of testosterone, like a cypionate or an enanthate, which are pretty similar. It works out on a weekly basis. It just so happens it works out pretty well for most patients. So you just remember, okay, every Sunday I'm going to do my injection. Mm-hmm. We have another ester called undecanoate, which is proven to be just a hassle to try and even find it. But it's a much longer lasting ester. They also use them orally, but for the injectable, which would mean, okay, presumably you could maybe inject every 3 weeks instead of a week. You just can't get it. And I think it might have something to do with one of the warnings is that it can create, what's the word? I think the warning says it might cause a thrombus, which is going to scare a lot of people, including docs, away. And I don't know why that's on there, because that opens up a whole other can of worms about testosterone, because that's one of the things that a lot of doctors claim also that, oh, well, you can increase your risk of stroke. And this rise in hemoglobin hematocrit is evidence of that. If you talk to a hematologist, they'll laugh. Okay, increased viscosity does not mean that you're going to get a stroke. And while we're on the topic, or I brought us on the topic, I'll say 2 studies that I'm aware of will clearly show that depending upon the studies, either 6 months or 9 months in, for those 6 or 9 months, if you have a pre-existing issue with blood, a coagulopathy, an issue with clotting too easily, then it will exacerbate it for 6 to 9 months, and it goes back to the normal risk of anyone else, right? So again, did testosterone cause that? No more than LDL causes coronary artery disease. No, it can contribute to it if you have a pre-existing condition, but these are typically very rare. As a matter of fact, the standard human being has what we call is heterozygous for a clotting disorder, Leiden factor 5. So it's normal for most of us to have one Leiden factor 5 gene and not. So the other coagulopathies are even more rare. Okay, and those are the ones we're talking about. So my point is, the chances of you having an issue with clotting when you take testosterone are very, very low, such that anyone who administers it typically doesn't even test for these things. Okay.
Interesting.
You could argue that you should, maybe, because of the slight increased risk. But even then, those that have the coagulopathy, the increased risk of a thrombus forming at all is also very, very small. So again,